What glides, what motions have we learned thus far? And the glenohumeral joint. Inferior glide, okay? Anterior glide, posterior glide. This is a lateral distraction, okay? So it's not as much of a glide, it's more of a distraction. Typically, in most joint complexes, when you hear distraction, you think you're going to think joint play or component motion. Joint play, okay? So this is a joint play. This will improve all classical motions of the glenohumeral joint. So it can improve flexion, extension, okay, external rotation, internal rotation, horizontal abduction, horizontal adduction. It's going to improve all classical motions. Okay, but a lateral, away from midline, distraction. So my patient is here. Okay, we're going to put them in somewhat of a loose packed position. I don't know if it describes that there, but you usually want to start fairly loose packed. Arm at the side, so she's in slight flexion, slight abduction, okay, maybe slight external rotation. I'm going to come up here with my towel roll, and I'm going to apply a fulcrum. I'm just going to put my hand here, and I'm just going to stabilize her arm in that position, okay? So I'm going to take my other hand, and I'm going to cup her at the distal humerus, so I can grab these epicondyles, okay? They make a good handle, and I can apply a little bit of a humeral, an inferior distraction, and then I can press in with counter pressure of my right hand to create a fulcrum to create a lateral distraction of the humeral head. Okay? And I can do the same thing. Here, I can apply a little bit of an inferior and then a counter pressure with a fulcrum to try to apply a lateral distraction. Okay? So that's the long lever arm. Now the short lever arm is your next slide. Position, okay, to where I can get here like so. I've got her, I would get myself squatted. I may bring the table up just a little bit, but I feel like I've got pretty good leverage right here. So I can do the same thing. I've got one hand that's applying a lateral distraction. I'm getting as close to the joint line as I can. I'm getting up into her axilla, coming out here, going lateral with my left hand, and then I'm applying just a little bit of counter pressure at the distal humerus with my right hand, okay? Good biomechanics. Distracting lateral, okay? So we'll let Jackson tell us about Cosen's test.
Okay.
Resistive tennis elbow test.
So, kind of hard one for everybody to see, but
Okay.
So you'll start with patient in neutral and stabilizing the elbow, and this will be a test you'll do resistance against pronation, extension, and radial deviation. And a positive test would be reproduction of symptoms that would be indicative of lateral epicondylitis. So you'll start with them first pronating. So you'll pronate against, and then you'll radial deviate against resistance, and then extend the wrist. So it's like this motion. You'll go here and then up with the wrist.
You kind of do them all at the same time, right? So you're going to pronate, radially deviate, and extend. And I know it says stabilize in your book, but as you're stabilizing, you're palpating that lateral epicondyle, that common extensor tendon, so you can feel what's going on there, if that's aggravating as you do this. Okay? So I know it says stabilize, but it's kind of a palpation to stabilize. You're going to allow them to go through the motion at the elbow, but you're going to provide resistance with the distal hand.
Breathe in. Anything with them? All right. So that would be a negative find for Cosen's test.
How do you know it's negative? Well, it's negative, but how would you know if that's normal for him?
Test it on the other side.
Yes. Okay. Make sure you do both sides.
Okay. The next one's Maudsley's. It's also for lateral epicondylitis. So we'll stabilize at the elbow again, but palpating still, and one hand on the palm on the dorsal aspect just distal to the proximal interphalangeal joint of the third digit. So get at their middle finger, they'll be in full pronation. And they're just going to extend their middle finger against resistance. So, whenever you're ready. Any pain with that? Okay. So that would also be a negative sign. So you, as the exam, this is Mill's test. This is also for lateral epicondylitis. You're going to passively pronate their forearm and flex their wrist over the table. And this should, for a positive finding, this would reproduce their symptoms. So, relax for me. Let me know if you have any pain with this. Any pain?
Alright, okay, so sit or stand. And then you have them make a fist on the involved side. And the examiner, we face it and we're looking at the medial epicondyle. Medial epicondyle. So the examiner passively supinates the forearm and extend the elbow and wrist. You have any pain over here? Medial side? No? You good? So it'll be a negative test. Well, you don't know, you gotta test the other side. You have epicondyle. Supinate. See. Oh, let me see the elbow. Any pain? All right.
So what is that test comparable to with the lateral epicondylitis? Mills, right? So again, it's a passive stretch. So we do one to passively stretch the extensors to look at the lateral the lateral epicondyle, the lateral common extensor tendon, right? Muscles attached there. And then we do one to passively stretch the medial to check the medial the flexors on the medial side, like the test first.
Yeah. Well, the elbow flexion test, you just hold the elbow flexion for 3 to 5 minutes, eh? Alright, if you start feeling some radiating pain in that median nerve distribution, it's positive. Lateral forearm and tip of thumb, index and middle finger, lateral half of index finger is a positive finding. And this could indicate cubital fossa syndrome.
Cubital fossa. What nerve did she say could be?
What
involved?
nerve?
Yeah. And what fingers might we see symptoms in if it's medial?
Again, it was the tip of the thumb, index, and middle finger. And the lateral half of the index finger.
Okay.
Alright, and then the last one is tendon signs. With this, you want to stabilize the wrist and then put your hand over in the area between the ulnar notch and the olecranon. This way you can feel that ulnar nerve. With only 1 or 2 fingers. Don't try to put all 4 in there. Okay? And if they feel some tingling in the ulnar distribution of the forearm, it could be indicative of ulnar nerve compromise. Alright. There it is. You're going to put your hand. So you're going to have your elbows flexed from 20 to 30 degrees. You're going to have your distal hand around the wrist. You're going to have your proximal hand around the medial side of the elbow joint. And so what you're going to do is you're going to apply your force laterally. So here, and just apply a lateral force. And then with the vagus test, you're
You're just gonna put your hand on the lateral side and you're gonna apply your force medially.
Alright, so what would be indicative of a positive finding?
Compared to the uninvolved side, they will have pain. For the varus test, they will have pain on the lateral side, and for the valgus test, they will have pain on the medial side, or they will be more lax.
Okay. So it could be pain, they may not have any pain at all though. So how would you determine if someone is more lax?
Like we'll compare bilateral.
Compare to the other side, what would it feel like if somebody's more lax? Increased restriction.
Over.
Resistance. Alright. So maybe excessive translation, okay, or excessive gapping or opening. Maybe there's not an abrupt stop. Now the other one that's up here, it's not really in your book, but it says functional test assessment. Turn the doorknob clockwise and counterclockwise. Okay, and what I think that really is, I think that what Dr. Carter's getting at with that is just, it's a functional task that you can do. You know, with the shoulder, we talked about athlete stretch test, how you could try to do certain motions here, they're functional motions. It allows you to tie something to their functional abilities, okay? So when we're talking about elbow complex, that's a task that you can use to assess functional ability with something, especially pronation and supination. So you could document a person has pain or difficulty with turning a doorknob clockwise or counterclockwise. That is essentially the doorknob assessment functional test, okay? So if you were to be asked the question, what's a functional test you can do to assess a person's ability to perform pronation and supination? What is the answer you can give?
Open the key.
Okay. All right, so you've got a test. All right, so I'm going to come in here, and so even with my stabilizing hand, I'm going to go ahead and bunch the skin. So as I come in here to his humerus, I'm going to come in, I'm going to bunch skin down. I'm sorry, my hands are freezing. Okay? And then I'm going to get him here like this. Now with my other hand, so my outside hand is going to be my stabilizing hand. My inside hand is going to be my mobilizing hand. And sometimes if I feel like his arm is flopping, I may even get in here and like nudge him to stabilize him, but I think he's okay. Now I'm going to bunch skin down this way, remembering that the ulna is on the medial side in this position because we're in an anatomical position. He's slightly supinated, okay? Because he's loose back. Now I'm going to sink through the soft tissue. There's a lot of soft tissue here. So I got to sink through until I feel like I've grabbed the ulna. So I've bunched skin, I'm near the joint line, I know I'm right as close to the joint line as I can get, and then I'm going to sink through the tissue and I'm going to apply a distraction of the ulna away from the humerus. Okay, is that pressure okay through your forearm? Okay, check with your patient. Again, it's a pretty strong squeeze, okay? So I'm here, stabilizing, bunching skin, sinking through so I can grab the ulna, and then I'm distracting the ulna, so 45 degrees perpendicular to that concave humerus going out, okay? All right. If I'm gonna do it in a seated position, again, I'm gonna try to get that person fairly loose packed, so they're in slight flexion, okay? There's a little bit of flexion, and I'm gonna let his forearm rest here. Now, if for some reason when I do that with him, he's in excessive pronation, supination, I might have to get him positioned with a pillow or something like that. That's a fairly neutral loose pack position. So again, I want to find the joint line. So if you remember earlier, we did this to ourselves. We got in here and we found radial head, humerus. We felt that gap. Okay, so I can come in here and I can find that again. So if I move his arm up and if I move it to flexion extension, I should be able to find that gap. So right here is the joint. Okay, so I'm going to get him positioned. So I found it. There's my joint line. There's the gap right there. Now I know I need to stabilize the humerus, and I'm going to mobilize the radius. Okay, so I'm going to bunch skin as I come in, and I'm going to stabilize the humerus. I'm going to do this seated in this position. Do you mind to bring the table up for me a little bit, please? Good, thank you. Okay, so that allows me to have good body mechanics as I get here like this. gonna take so I've got my finger on the posterior part of the humerus, but I've got to, if I'm gonna do a posterior glide, I've got to apply it from the anterior position to the posterior, right? So I'm gonna come in here with my hand, I'm gonna bunch the skin, and then I'm gonna sink through, and I'm gonna get a hold of the radius. Now from here, in my mind, if you look at the model there, I'm envisioning that the concave surface of the radial head, and I'm going to apply a glide parallel to the concave surface. Okay. Yep, if you just relax your arm is going to move because I'm moving your arm, but it's okay. Pressure okay? And I'm taking him to end range and feeling that, okay? Coming here, I'm gonna bunch skin, I'm gonna stabilize. Bunch skin, get close to the joint line, here's his joint line. I'm gonna reach through, I'm gonna sink through the soft tissue to get a hold of his radius, and I'm gonna apply a glide parallel to the concave surface, the humeral head. If I reach across. So if I reach across, and it's a little harder for me because I'm not quite as tall. Some of you, this may be a more effective technique. But pretend like I'm big and tall and I have really long arms. This is not the best for me. This would not be great body mechanics, but I want you to understand the concept. Coming here, same thing. I'm going to bunch skin. I'm going to get a hold of his radius. Now, I've got him here, and instead of pulling, I can push. Okay? Now, I will kind of even get like this. So sometimes my thumb might be nubby pushing through here. So if I get him with a good enough grip like this, I can get my thumb out of the way, and now that's a more tolerated, usually, position. I can do a good posterior glide. I feel like I've got more force, okay? Like I can get a little more oomph behind it if I need it, but that's what it would look like from that position. Again, for Tavian, I would say it was grade 3. I didn't feel much difference. Could you feel much difference? They felt fairly symmetrical, nothing abnormal, smooth quality of motion. Normal for a minute. So again, I can get Saul-Miller's grip like this. Now my thenar eminence is against her thenar eminence. I'm going to come in, I'm going to bunch skin and just get in a habit of bunching skin. Okay, I'm going to stabilize the humerus, and then I'm going to get my forearm in line with her forearm. You okay with that pressure? Okay. And then I'm going to apply. Doesn't take a lot of pressure from Tia. Okay. But again, there's a lot to compress here and work through the slack. First of all, my elbow. Then I got to take up the slack as I push through my wrist. Then into her wrist to transmit force to the radius. And with my thumb here, I've got my finger in that groove. So that when I do this, I can feel that radius move. I can feel that space right there getting smaller, because I'm pushing the radius toward the humerus. So that gap between the radius and the humerus is gonna become smaller. Does that make sense? All right, so that is the cephalic. And again, we're just doing assessment. So again, I've got a couple ways I can do this. I can come here and stabilize humerus. Now to do the caudal motion, I'm gonna grasp the radius with this kind of grasp. I'm gonna come in here, I'm gonna bunch skin, stabilize the humerus. Now look how much skin stretch happens as I go to do this. There's a lot of skin stretch to take up before, like I've moved this much before I've even gotten to the bone to be able to pull it. Now I'm gonna pull caudal. Now I can keep my index finger now right on the joint line. Stabilize, and I can pull. Now what will I feel that space do? Widen, okay? So I can do it like that. I can stand, if you just wanna have good body mechanics, it's kind of an awkward position. You can play around with that a little bit. This is what works best for me. I feel like that's where I can get the best grasp and the best pull. My forearm, again, is still in line with her forearm.